just want to thank everybody for being here this morning. We wanted to take this opportunity to give you an update about our planned change or our change to reflex testing for high-grade lymphoma at UHN. This is a change that we've been hoping to implement internally for a while. And we just wanted to basically lay out the rationale to give a little bit more detail about the change, and then to run through some of the practical issues in terms of things like, you know, how do you actually order the test now? We have a new version of our requisition that's a little bit different than the old one, and what happens, what the reports are going to look like, etc. And so without too much further ado, I'm going to hand over the presentation for the first part to Dr. Rosemary Tremblay-Lemay, who is a hematopathologist at UHN and has worked with the Cancer Cytogenetics Lab to help implement this change to improve our sensitivity and workflow for this lymphoma testing. So thank you very much. Rosemary?
Yeah, can you switch to the next slide, please? Thank you. As you all know, there's a new diagnostic category, which is the high-grade B-cell lymphoma with double hit, triple hit, that was introduced in the WHO 2016 classification. And so now there's the category of the high-grade B-cell lymphoma, which is divided in the NOS category and the double hit, triple hit category. And it's defined by the presence of MYC and BCL2 and or BCL6 rearrangements identified by FISH. And as you know, the reason why we care about identifying these patients is because they tend to have a more aggressive clinical course, and patients tend to respond poorly to standard DLBCL therapy. Therefore, that can be an impact on management because they can get a more aggressive treatment. Can we switch the slide? And so the issue arises from the fact that in terms of the morphology, about 50% of the double hit, triple hit will have a so-called conventional DLBCL morphology, but only 48% of the DLBCL are effectively double hit, triple hit. And therefore, the question that is asked is, should we test all DLBCL cases to identify the ones that have the rearrangements? And in terms of the current WHO classification, basically it says that a consensus has not yet been reached to provide specific guidelines as to which large B-cell lymphomas should have FISH studies. And so there are some that believe that all cases should be tested, whereas others would limit, for example, to cases with a GCB phenotype and or high-grade morphology, or to cases with more than 40% MYC positive cells by immunohistochemistry. And so there are a variety of screening strategies that have been described in the literature. So one can go about it based on the cell of origin and focus on the cases that have a GCB phenotype. This can also be combined with the double protein expression by immunohistochemistry. There has been a bit of work done to look at whether Ki67 expression could be used. However, it's been shown to be less sensitive, and also a low proliferation rate in the DLBCL does not necessarily exclude double hit, triple hit. Therefore, it's not really a recommended strategy. And so just a short word on double protein expression. So double protein expression itself has some prognostic value. However, it cannot be used as a surrogate for cytogenetic status. So most double hit, triple hit are also double expressors, but most double protein expressors are not double hit, triple hit. The majority are actually ABC subtype DLBCL that do not have the translocation, but it can be used as part of selection strategies. And so the reason why we decided to revise our workflow for the FISH testing of these cases is from this publication in Blood in 2018, where they effectively looked at a large series of DLBCL cases, and they systematically performed cell of origin both by immunohistochemistry and by molecular. They looked at double protein expression, and they looked at a combination of cell of origin and double protein expression. And then they had also done FISH on all cases, and they compared the sensitivity and specificity of all these screening methods. And basically, as one can expect, the only way to have 100% sensitivity is to test all cases. And then by using these screening strategy, we increase the specificity, but we sacrifice some of the sensitivity. So can we switch to the next slide? So, however, one thing that they suggested is effectively to start by doing, a testing that is done in two parts. So instead of doing all 3 probes on all cases that we want to test, they suggested to do MYC only on all cases. And then based on their data, you would expect to have about 12% of cases that will be positive. And then those positive cases can be further tested for BCL2 and BCL6. And really the problem with the screening strategy using the cell of origin is that it's very good to identify the MYC BCL2 and the triple hit cases, but it will miss a percentage of the MYC BCL6 cases. And we know that there's a little bit of controversy in the literature as to whether these patients really behave as aggressively as the MYC BCL2 or triple hit, but through discussion with our clinician, their conclusions were that at the moment, this is part of the WHO definition for the double hit, triple hit lymphoma, and they would potentially consider changing the management. And therefore, at least at the moment, there is still value in making sure that we don't miss those MYC BCL6 cases, which is why we decided to move to an approach where we test MYC on all of our DLBCL cases, and then we will have the reflex testing when MYC is positive. And I will turn it to you, Adam.
Thank you, Rosemary. So just to give everybody a little bit of background on the testing we do at UHN and on the actual practical applications, I'll just present a few items about what we've looked at internally and what we're going to change doing. So in 2018, we were doing all of these probes concurrently. If we look at the UHN testing, only the internal testing, testing using a screening strategy, you can see that we had the majority of cases that we tested were actually negative, and about 20% of cases had either a MYC only rearrangement, had a MYC BCL2 rearrangement, or in fact were triple hit. And in our set in 2018, we didn't have any cases that had a MYC BCL6 rearrangement, and this was due to the fact this is a fairly small sample size. When we take the sample size up to all referred in testing, you can see that now we do see some cases that were both MYC positive and BCL6 positive. But you can see again, that's about 20%. And then depending on the referrer, different people that send us samples do actually have different referral criteria for testing. So again, part of the motivation here is to try to standardize the testing and to also make it practical from a workflow point of view and from an economic point of view. So just a little bit of very basic FISH probe design, just to talk about the different kinds of FISH probes that we use on this assay. We are switching now to mainly only break apart probes in the FISH probe design. So for MYC, BCL2, and BCL6, we're now going to be switching to a break apart probe strategy. This is a probe where the gene basically that is of interest, for example, MYC, has a 2-color probe, one on the 5' and the 3' end, and in a normal interphase, nuclei would show a 2-fusion pattern. And when there's a rearrangement, this breaks one of the signals apart and separates these two probes, the 5' and the 3' probe, so that you get a separated or broken signal pattern. And so this is a positive nuclei for a break apart probe. We were using, basically right up until about this week, the IGH BCL2 dual fusion probe. So where you would, for example, have the IGH probe in green and the BCL2 probe in red. Please disregard the size of the chromosomes there. This isn't specifically an IGH BCL2 example. But what would happen is normally you would see that you wouldn't have any co-localization of the IGH or the BCL2 probes in a normal nuclei. You just have two signals for each chromosome. And then only when you had a rearrangement between the IGH and BCL2 locus would you then get two fusions and a red and a green in a standard classic translocation 1418. Of course, if there was more complex rearrangements, you could see additional abnormal signal patterns. So this is basically what a MYC break apart probe looks like. The MYC gene is here, the 5' end of the MYC gene and the 3' end of the MYC gene on chromosome 8q24. It has an orange or red colored probe on the 5' end and a green colored probe on the 3' end. There's a lot of space in here because MYC rearrangements are known to occur over a large region of a gap of approximately 400 kilobases, because the MYC gene only has to translocate, for example, into association with the IGH enhancers, for example, for it to be driven, or another region where it's driven by another set of enhancers. So in practice, this is what it looks like. This is a normal image of a non-rearranged sample with the MYC probe, where you can see these two fusions. There's fusions basically in every cell where the red and the green probe are very close together. In a positive, what you see is these signals broken apart. So you will see some fusions. There will always be some fusions, but then you will see these red and green signals that are separated, and that gives you a positive signal pattern. For BCL2, as I mentioned, we are switching from the dual color, dual fusion probe design, where we have a probe for IGH and a probe for BCL2, to a BCL2 dual color break apart probe. And part of the reason here is just purely based on the definition of a double hit in the WHO, which is any lymphoma that has a MYC rearrangement and a BCL2 rearrangement, not specifically an IGH BCL2 rearrangement. Although we do expect that most the BCL2 positive cases will actually be IGH BCL2. And internally, we will be reflexing to the IGH BCL2 probe just to look and see what the level of positivity for 1418 is after the BCL2 break apart probe. The BCL2 break apart probe is actually easier to score in paraffin tissue than the IGH BCL2 probe, which is one of the other practical reasons for switching to this BCL2 break apart probe. As you can see, the scoring for IGH BCL2 and surgical FFPEs can get a little bit complicated. So this is a non-rearranged tissue on the left, where you see very few co-localizations of IGH and BCL2 probes. You do see some occasionally, and this is just simply because of the three-dimensional orientation of the nucleus. Sometimes you can have an IGH BCL2 actually overlap in the Z plane, and so they appear to be a fusion, but it's not a real fusion.
That is a bad one.
And then again, positive nuclei, you can see over here, there's lots of fusions associating the IGH and BCL2 signals together. Okay, and this is just a close-up view of this region here, showing some clear fusions, and then the other red and green signals from the normal chromosome 14 and 18 that you would expect. The final probe on the panel is, of course, the dual color BCL6 break apart probe, which is, again, very like the MYC and the BCL2 break apart probe. We have a red and a green probe flanking the gene on the 5' and the 3' end, looking for rearrangements. So our current workflow basically involves the usual processing of a tissue when it comes into the lab, reviewing of H&E slides, processing of IHC and reporting of IHC. And then what we would do at this point is order fish, and then we would try to report that fish out as quickly as possible. On the new proposed workflow, everything's going to remain pretty much the same. And it's, again, for your workflows, for the external institutions that are referring in, at this point, you know, where you would say this is a large B-cell lymphoma and you're going to send for fish, you would send out, we would fish all cases for MIC right up front. And we're working on we've changed the procedures in the laboratory to try and speed up the reflex. So we're hoping that we're going to get this MIC fish out in 5 days or less, and then hopefully in 2 or 3 days we're going to get out the BCL2 and BCL6. And remember that based on the literature, we believe and our own experience that the positivity rate for MIC is actually going to be fairly low. It's going to be around 10 to 15% probably. So we're not going to be reflexing a ton of cases, and that's going to help us move these cases through faster than we are if we had to test all DLBCL with all 3 probes. So the ideas here basically are to optimize the financial and operational impact. So we had been requested in the lab to actually test all DLBCL from our own hematopathology team at UHN. And of course, if we were to do this using the original workflow, it would indicate it would cause a significant increase in cost for us and a significant increase in workload for the lab. It would increase overall the amount of fish we were doing approximately 30 to 40% for lymphoma. So it was a significant request. And so this is where the reflex testing strategy comes in. The reflex testing strategy allows us to mitigate that increased cost and workload. It gives us an increased sensitivity benefit. It can potentially reduce other screening costs that might be incurred by providing a highly sensitive approach to detecting double and triple hit lymphomas. And there will be a slight increase to receiving the BCL2 and BCL6 final status, so the final diagnostic status of the tumor will be a little bit longer, but we do hope that based on this change, we will see a decrease in the reporting time for MIC. So that initial MIC positivity will come out quickly and then be followed within a few days with BCL2 and BCL6 status. From a financial point of view, depending on what your pattern was of referral, depending on how much of your diffuse large B-cell lymphoma you were already sending to UHN, you could see significant cost savings from this approach. On the email that I sent out, we did send out a copy of this calculator. So if you do want to give it a try with your own institution's numbers, you can put it in and get kind of a ballpark idea of what would happen. This is UHN's numbers from 2018. So we had a total number of 137 diffuse large B-cell cases. Of this, 81 were sent for fish, and that works out to approximately 243 total fish hybridizations and a total fish cost of about $73,000. In the reflex model, we'd still have 137 total DLBCL cases. We would send all 137 for fish, but based on the reflex model, we'd only end up performing about 192 hybridizations. So that's a fairly significant decrease in the number of hybridizations and a significant cost savings to us in terms of both cost, probe cost, and labor. And so again, so for those centers that are considering that maybe not sending all of their DLBCL, this is a consideration right now that should hopefully provide a financial benefit. So how to order, this is just a very quick overview. Most of you are already ordering already, but I just, I wanted to go over this very, very quickly just to highlight the changes in the requisition. And if you were also, for other individuals that were helping to do these sendouts in your laboratory areas, that you may wish to forward them this information if it is helpful. So basically, it's very simple. You can go to our website. You can then click on Services for Physicians, okay? And when the Services for Physicians page opens up, there is a link to our new requisition. You can click on the link to the requisition, and on page 4, which is the cytogenetic testing, there is a box at the bottom for lymphoid disorders, and you can see that our large B-cell lymphoma panel is here. So all you have to do if you want the reflex panel is check this box and send the sample to us, and that's all there is to it. This is a slight change from the previous requisition where we had our high-grade lymphoma panel here, where we would do everything concurrently. If for a clinical reason it's necessary for you that you want all three results as quickly as possible, you can send us an email at cancercytogenetics@UHN, say you've sent in a sample, you need concurrent testing because the patient is in a critical state and you don't want to wait the extra 2 or 3 days for the reflex, and we can go ahead and do that for you. And then just finally, we did change our report templates somewhat. You will see a slight difference on these report templates when they come out. And I just wanted to sort of highlight the differences. So we have a negative reflex panel here. So what happens is that MYC gets tested, it's negative, and therefore no reflex is performed. So you'll see the BCL2 and BCL6 reported as not tested. MYC positive, reflex in progress. So this is a sort of a provisional report. It will come out saying MYC is positive and the other 2 probes are in progress. And then once the reflex panel a few days later is completed, you'll get an amended report with the additional information of the other 2 probes saying, you know, they're either positive or negative, it's a double hit or triple hit, or it's just a MYC positive lymphoma. And so that's what things are going to look like now. So finally, just to conclude our presentation, we know that there is variation in practice between hospitals in Ontario and how these diffuse large or large B-cell lymphomas are triaged in terms of what tests they receive. And so we hope that this is a step towards standardization of practice. Selection methods based on cell of origin or dual protein expression will reveal most cases and their prognosis, but there is still a subset that would be missed by using these selection methods. So specifically the ABC type lymphomas that are potentially double hits. And this 2-step approach that we've proposed will find all cases with reasonable cost and can be applied to all institutions, hopefully. So there are some references there, and you know, at this point, we're happy to take any questions from anybody who's calling in. And we are switching over our to the new reflex panel this week. We have all the changes, the in-lab changes in place. And so I'll open it up in case there's any questions or concerns from the group.